This video describes using top tools and resources for clozapine initiation in community. I'm Jessica Ananuevo, clinical nurse educator for the Treatment Optimization of Psychosis Collaborative. We will cover why treatment optimization of psychosis is important in the community, top workflows, the protocols when initiating clozapine in the community setting, and we will also go over the tools and resources for healthcare providers, clients, and their families. After watching this video, you will learn how to identify clients who may benefit from psychosis treatment optimization, generate a plan to assess and manage side effects of clozapine in community, and locate experts and services to support clients in the context of treatment resistant schizophrenia. Schizophrenia affects 1 in 100 people. That's 24 million people worldwide, 376,000 people in Canada, and about 50,000 people in British Columbia. 1 in 4 adults who have schizophrenia or schizoaffective disorder meet the criteria for treatment resistant schizophrenia. TRS is when a person has not responded to 2 antipsychotics. The Canadian Schizophrenia Guidelines recommends clozapine for TRS. 30 to 60% of people with TRS respond to clozapine. However, clozapine is severely underutilized despite this being the recommended treatment for TRS. Inadequate treatment of schizophrenia means individuals face greater discrimination, social isolation, withdrawal, homelessness, suicide, and burden to caregivers. It also means people living with psychosis undergo multiple relapses and hospitalizations before being considered for medications such as depot injections and clozapine. On the left here, we have an article from the Vancouver Sun describing that BC has the second highest hospital readmission rate in Canada. On the right here, we have data from the Canadian Institute of Health Information, which indicates that in BC, those with schizophrenia or psychotic disorders spend more days in hospital for acute psychiatric care, and that lengthy hospital stays are associated with high risk of readmission. Optimizing psychosis treatment in the community increases timely and accessible care and decreases hospital utilization. This is also to improve personal and functional recovery in clients with psychosis, to initiate clozapine earlier for clients with TRS, which may increase its effectiveness, and to also provide a standardized approach to care, shifting clozapine initiation from acute or subacute care settings to community. Here we have the top tools and resources story or process. We first start off with identifying a client who may benefit from treatment optimization of psychosis and determine a care management strategy. Then, from what is determined from the care plan, psychoeducation and motivational interviewing is provided to the client. Then, if it's determined that the client has treatment resistant schizophrenia, we get into using the top tools and resources in planning and monitoring care during the clozapine titration. Lastly, maintaining a client on clozapine. Our case study here is Samuel Toole. He was named after the Screen and Manage tool, or the SAM tool for short. So he's a 42-year-old Asian male. His pronouns are he, him, his. A few months ago, his girlfriend ended their long term relationship as she decided to move back east with her family. This was a significant loss for Samuel because his girlfriend was a primary support person in his life. Because of their ended relationship, he moved to Francis' house to live on his own. He volunteers twice a week at the library, and he sees his best friend John regularly to go bowling. He's transferring from the Kitsilano mental health team to the Grandview Woodlands team. He regularly attends his appointments with his previous team for his depot, and he's supported by PWD. Samuel is a moderate smoker and smokes about 2 packs a week. He doesn't have any medical complications and he's connected with a GP. Samuel reports having a depressed mood, restlessness, and mild irritability and sleep disturbances. He's also having an increase of auditory hallucinations in the last 2 months that are not command in nature, and he reports to his case manager that he's been using loxapine PRN while he's volunteering sometimes because the voices get very bothersome. His last HONOS was completed and scored 3 on question number 6. His client service priority score is 3. His diagnosis is schizophrenia. His current medications include sertraline, olanzapine, risperidone IM, and loxapine PRN. We identify clients that may benefit from optimizing their psychosis treatment through intake assessment, transfer of care, and client family self report. So, in Samuel's case here, we identify the client through the transfer of care as he's transferring from the Kitsilano team to the Grandview Woodlands team. We can also identify clients through client care reviews. So, that's um, doing the morning huddles, weekly or monthly care reviews, the positive and negative syndrome scale short version, which is recommended to be done every 3 months as per the treatment response and resistance in psychosis guidelines, and also the HONOS assessment, which is a mandatory assessment done every 6 months as per the Ministry of Health. And this is where we're taking a look at clients scoring 3 or more on question number 6 that looks at problems with delusions and hallucinations. We can also identify clients for psychosis treatment optimization when it is clinically indicated by psychiatric assessment. And also taking a look at a client service priority score, seeing who we are triaging care to see whether there are barriers to recovery to address or a need to optimize in their medications. Once you've identified a client that may benefit from psychosis treatment optimization, you can then use the Top Screen and Manage tool to help you determine a care management strategy for your client. This tool is designed to support clinicians in practice to screen for possible barriers to recovery in people living with schizophrenia and schizoaffective disorder. It is a collaborative tool used by physicians, case managers, and care coordinators. It can be accessed by different levels of care delivery within VCH, as this tool will be live on Paris. It is based on the Canadian Schizophrenia Guidelines, and it is a place to document and organize clinical information. So, this is the paper pilot version of the Screen and Manage tool, which will be similar when this is on Paris. And so we have one initiated by me here as Samuel's case manager, and I collaborate with Dr. Neela Kant, who is Samuel's psychiatrist, in the completion of this document. This goes over a series of questions, and we end the screening portion at question 10 here, in which the Screen and Manage tool indicates that the client may benefit from a clozapine trial. And the next steps in terms of care management strategy is to provide psychoeducation. And we can also involve the client's friend John in his care. The Screen and Manage tool has a portion to indicate the treatment initialization or optimization flow sheet. So, whether a client is starting a depot or clozapine. In our case study here, Samuel will start clozapine. This also contains the HONOS and PANS short version as baseline assessment tools to measure treatment outcomes. The HONOS can be filled out by the case manager or physician, and the PANS short version is completed by the physician. This document describes the criteria for clozapine initiation at VCH or Vancouver sites. The criteria for starting clozapine in community are based on the CPA schizophrenia guidelines, and that each case should be considered individually. For clients starting clozapine in community, they have a primary care provider, not homeless, or has a fixed address to live for the duration of the initiation at least, is reliable or has a reliable family or friend support. The client is not actively using substances in the immediate 4 weeks before, except for possibly cannabis and tobacco, and that the client has no medical complications. So, the main differences between clozapine initiations in community versus acute or subacute care settings are the client's risk of safety to self or others, whether they are presenting with complex comorbidities or complex polypharmacy, and also the rate at which the clozapine titration is going. A slow clozapine titration schedule is recommended for community, and that's looking at 1 to 2 increase in doses per week versus an increase in dose at a much faster rate, which is seen in acute and subacute care settings. So let's take a look at Samuel's stabilizing and destabilizing factors. We know that he has a social supports where he sees his friend John. He has stable housing and lives on his own. Samuel also has a routine in his life. He likes bowling and volunteers twice a week at the library. We also know that he regularly attends his appointments with his previous mental health team, and he's supported by PWD. And although he's a moderate smoker, he does not have any medical complications, and he's connected with a primary care provider. His destabilizing factors include that he has lost a significant primary support person in his life and is now living on his own. And it's clinically indicated by psychiatric assessment that he's experiencing some bothersome psychotic symptoms with the current medications that he's taking. When we take a look at Samuel's case study, he meets the criteria for starting clozapine in the community in that he has a primary care provider, has a reliable support person, and has a stable housing and regularly attends his appointments with his mental health team. And that despite him being a moderate smoker, he does not have any medical complications. The client and family education can include psychotherapy, so for example, CBT, DBT, motivational interviewing, group therapy, addiction management, involving the client in psychosocial rehabilitation groups, involving family or client support person in their care, encouraging the client's family or their support person to join family support groups, psychosis education, side effects management education. So, in the next few slides, we have educational resources you can share with your client when providing psychoeducation about treatment resistant schizophrenia and clozapine medication. This is an introductory resource you can provide your client when you first have a discussion about clozapine, which summarizes why clozapine is used for clients with treatment resistant schizophrenia. Next, we have a pamphlet which describes what clozapine is and the side effects for the client to watch out for. This is the clozapine titration information for the client and family. And this pamphlet has a place to organize the upcoming appointments, contact information of the client's mental health team, after hour support, reminder of their lab work day, and contact information for their primary care provider and pharmacy. And the second part of this pamphlet is a summary of the psychoeducation about clozapine and the side effects. Here we have a video that introduces clozapine when a client is starting clozapine in community. This video is available on the VCH Documents for Clinical Care or the TOP Collaborative website to view. The top tools in planning care include the clozapine start, transfer, discharge guideline, the information we send to the client's primary care provider when a client is on a clozapine titration, and the clozapine titration schedules for the physicians. The clozapine start, transfer, discharge guideline lists the administrative processes of clozapine initiation and registration. It starts with step 1 here with obtaining informed consent from the client and sharing this information with their family or support person. Then, depending on where the clozapine is being started, you will proceed to that following step. In Samuel's case, we go to step 2 as he's initiating clozapine at his mental health team. This guideline organizes the administrative tasks associated with the clozapine initiation and the roles on who completes the task. A slow titration schedule is recommended for community initiation of clozapine, and that clozapine dose increases are recommended between Monday and Thursday. The clozapine titration schedule that Dr. Neelakan has chosen for Samuel is the weekly clozapine titration chart. This is looking at 1 dose increase per week. The variable titration chart we have on the left here are for clients who require a much slower titration schedule, and perhaps starting at 6.25 milligrams. This can also be used for clients who have been on clozapine for a long time and had no side effects, and for some reason had stopped clozapine, and the physician is titrating from half the original dose. These titration charts supplement the yellow sheet that the physician writes their medications for the client. Before a client starts clozapine, the team notifies the client's primary care provider that the client will be on a clozapine titration, and we can send this information sheet which lists the common side effects and their management. If the client is not connected with primary care, we can send a primary care referral to the Patient Attachment Initiative. The top tools and resources to monitor care during a clozapine titration include the Clozapine Monitoring and Management in Community algorithm, which is in the VCH Decision Support tool, the Vitals, the Clozapine Vitals and Adverse Effects Monitoring Sheet, the Metabolic Monitoring tool, and the Primary Care and Specialist Resource Pathway. The key highlights of the clozapine monitoring and management in community algorithm are that the day after an increase in dose, the client is assessed by a nurse for vital signs and adverse effects monitoring, and that weekly blood work is reviewed by the physician and nurse. So with the red arrow here, we have the postural blood pressure and heart rate, temperature, assessing signs and symptoms of infection or myocarditis and other adverse effects done within 24 hours of increase in dose. So, for example, if Samuel takes his clozapine on Tuesday, he will then come to the team the following day on Wednesday to have his vitals checked, and the nurse will assess signs and symptoms for myocarditis, infection, and other side effects. Myocarditis, neutropenia, or agranulocytosis are the major adverse effects to monitor while a client is on clozapine. Signs of myocarditis are lightheadedness or dizziness, chest pain, fatigue, shortness of breath, peripheral edema, palpitations, flu like symptoms, and fever. Signs of neutropenia or agranulocytosis are fever, muscle aches, sore throat, headache, diarrhea, or any infection. Other key highlights of the algorithm here is that the nurse reports the following to the physician: any signs or symptoms of myocarditis and infection, WBC and ANC in yellow, yellow drop, or red zones, CRP greater than or equal to 50 milligrams per liter, and any elevation in troponin. The clozapine vital and adverse effects monitoring sheet is completed by either nurse or physician. For sites using Paris, this is kept in the client's paper chart, and for sites using EMR, this is completed in the electronic health record. This top portion of the monitoring sheet is where we document the client's vitals, and then there are tiki boxes to indicate whether the client is showing signs of infection, myocarditis, and other adverse side effects. The metabolic monitoring tool is completed by the nurse or physician. This is documented in paper form and kept in the client's paper chart. Here is the primary care and specialist resource pathway. So, in the event a client is experiencing side effects, this pathway can help determine what medical attention or consult is needed. The red portion indicates when sending a client for immediate medical attention to ER. When sending the client to ER, the referring physician contacts the ER triage nurse to provide the presenting clinical issue and handover. The orange portion here indicates when a client requires urgent medical attention, in which a client needs to be seen within 12 to 24 hours. So, when a client is being sent for urgent medical attention, the client is sent to their GP. However, if the client cannot be seen by their GP within 12 to 24 hours, the client can be sent to a UPCC. When sending a client to a UPCC, the referring physician contacts the UPCC physician or nurse practitioner to discuss the clinical issue and desired treatment outcome followed by relevant client information by fax. The yellow portion indicates the in person, non urgent evaluations. Referral form information and contact information for hematology, cardiology, and primary care attachment can be found on the second page of this pathway. Lastly, the green portion here are for physicians for when they require phone consult advice only. There is the race line for real time advice, and they can also contact the client's registered closeting company to access specialists such as hematologists and cardiologists as well. The second page of this pathway lists the contact information of the resources. Some useful links we have here are links to ER or UPCC locations, and also a link to the estimated times at those locations. We also have the referral form information for cardiology and hematology referrals, and the contact information for primary care attachment. The third page of this pathway is the description of the resources and provides examples as well. In the event a client misses blood work, the drug manufacturer notifies the physician and case manager or care coordinator. The, the case manager or care coordinator contacts the client to complete the blood work as soon as possible, as the community pharmacy cannot dispense the clozapine medication unless the blood work is done. In the event that the client misses doses more than 48 hours, the client needs to be retitrated from the start. The client could start from half the original dose and titrate up the original dose if the client has been on clozapine for a long time with no major side effects. And the physician is to check for the latest missed doses protocol from the drug manufacturer. So, after each visit during the clozapine titration, a copy of the physician's Paris case note or EMR encounter note is sent to the primary care provider, and this is to update them on how the client is doing during the clozapine titration. When the client is successfully initiated on clozapine and later discharged to another team or another provider, the termination includes the following information: the clozapine start date, the clozapine drug manufacturer, the clozapine registration number, frequency of blood work, any altered parameters for blood work monitoring, the most recent clozapine level, and the last day of blood work, and any noticeable side effects that the client may experience. Here are the summary of roles and tasks during the clozapine titration. For the physician, they can complete the SAM tool, notify the primary care provider of the clozapine titration and any adverse events that happen. They rate the titration schedule, monitor for side effects. They complete the PANS short version and the HONOS. The nurse can initiate and collaborate with the SAM tool, notify the primary care provider of the clozapine titration and any adverse events that happen, monitor vitals and assess for side effects. They can complete the HONOS, and they notify the physician of any abnormal findings. Allied staff can initiate and collaborate with the SAM tool. They can notify the primary care provider of the clozapine titration and any adverse events. They can complete the HONOS, and they can notify the nurse or psychiatrist when a client is experiencing side effects. And the client or family need to know what side effects to watch out for, where to go for follow up care, check the check in appointments with mental health team, medication pickup, and weekly blood work. There's a lot of moving parts and collaboration during a clozapine titration, and the next step to care is maintaining a client on clozapine. This can start by having a discussion about next steps with the client and their family or support person and guiding them to the changes in their care plan as the frequency of their visits with their mental health team will lessen, for example. Providing ongoing psychoeducation and encouraging the client to attend side effect management groups, maintaining a list of clients on clozapine registration, and having a systematic approach to lab results and prescription follow-up. Lastly, consulting with a subject matter expert as needed. So here we go back to the screen and manage tool. As the case manager here, I'm collaborating again with Dr. Neelakan to complete this. I fill out the Honos score and then we'll pass this over to Dr. Neelakan to provide the PANS short version assessment. This is completed after the client completed the clozapine titration at optimal dosage or plasma level. Here is the psychosis management pathway that contains all the top tools and resources in one place. In the first section here in the square boxes, we have the clickable live links which correspond to the assessment steps circles below. The last section of this pathway has additional notes to each of the assessment steps. So we start at step 1 in identifying clients that may benefit from psychosis treatment optimization through intake, transfer of care, client care reviews, and as clinically indicated by psychiatric assessment. We can use the top screen and manage tool at the step to screen the client for possible barriers to recovery and help determine a care management strategy. Then, depending on what has been determined as a care management strategy, it may be identified that the care plan involves either um, depot or non-adherence management or TRS management. Psychoeducation is provided to the client. Then, if it is determined that the client has TRS, we move on to steps 3 to 5, which goes into planning and monitoring a client during a clozapine titration, and lastly, maintaining a client on clozapine. The psychosis management pathway is available on the VCH documents for clinical care. You can find the accredited top online course available on the Learning Hub, course code 27983. This course gives a comprehensive overview for caring for clients with psychosis and goes over topics like the Canadian Schizophrenia Guidelines, rating skills used to measure treatment outcomes, and motivational interviewing in the context of depots and clozapine. The decision support tool for clozapine monitoring and management in community is available on VCH Shop, and all of these tools and resources can be accessed on the VCH MHSU documents for clinical care. And thanks for watching.